Okay, I think we'll get started. It's 12:01. Welcome. My name is Mari Teitelbaum. I'm the Acting Director here at Born Ontario. And I just want to set the stage quickly to make sure everyone has an understanding of the scope of this call. We have had a number of questions, but essentially what we're doing is we've had incredible success with our Born Build briefings, a series of webinars introducing the Born technology and the changes you can expect with that change in technology over the coming months. And given that success, it was decided to replicate the model, essentially, to talk more about Born more broadly. So technology is absolutely part of what we do, but there's a lot more to the work of Born as well, and wanted to take the opportunity to share some of that with you, an opportunity for you to provide feedback, ask questions on the broader Born program, the broader Born organization, beyond just the build. So this session today is the first of the Born Ontario briefings, not a Born Build briefing, but a Born Ontario briefing. And this will be a very high-level introduction to Born Ontario. We'll touch on the technology, but really that's just one component of Born. We'll spend a lot more time on the core purposes, committees, et cetera, of Born during this session. All of your lines are muted, so you're not able to ask questions as we go. But if you do have a question to ask, just press 01 and you'll be placed in a queue, and we'll pick up questions at the end of the session. Or you can type your questions in the chat window on the webinar as well. So there's a couple of ways to ask questions. So with that and all that instruction, I think we'll dive right in. So I just wanted to start the session by recognizing midwifery, because in fact, May 5th is the International Day of the Midwife, essentially a day to highlight the commitment of the midwifery community to improving maternal and newborn health around the world. I have heard that in Ontario, midwives and their supporters are doing a 5K walk to raise awareness on exactly this, on the work of midwifery for maternal newborn health in Ontario, but also across the country and across the world. And so Born just wanted to take this opportunity to congratulate them and celebrate with them, as midwifery is a key partner in the work of Born. So congratulations to them. So from there, we're going to dive into a concept of facilitation of care, and it's really a core concept that drives the work of Born. And to help people understand what we mean by facilitation of care, I've got a few stories, essentially, to share with you. So imagine baby Mike is born in Markham at 30 weeks, but due to some challenges with his early birth, it's decided to transfer him to Mount Sinai in ICU, for example. Each of the sites may have thought the other completed the newborn screening test, but in fact, neither did. How is Newborn Screening Ontario going to find out that he's been missed? The newborn screening program has a very good understanding of who they have screened, but it's much more difficult to figure out who you have not screened. And so a story of facilitation of care would be being able to capture the fact that this baby was born but not screened. Another example of facilitating care to an individual is simply actually access to information. And this is my favorite story because it sort of kind of almost happened to me. But Sarah from Toronto is having a weekend away with her friends, and she's at 34 weeks in her pregnancy. But she has so much fun that weekend, actually ends up delivering unexpectedly at St. Joe's in London. Unfortunately, her antenatal 1 and antenatal 2 information is not in London, it's in Toronto. And how will the obstetrician have access to that information? And needing access for a couple of reasons. Obviously, there's key clinical information on those forms to help inform her care, but also there's a number of tests that would have to be redone, further loading the system from a resource perspective because they don't have the results of the tests that have already been completed. So being able to facilitate access to that information could make a significant difference to the care Sarah's being provided in London. Another form of access to information. A nurse manager in a labor and birth unit at a community hospital may have questions around the number of inductions that are happening. How can she actually have access to the true number being done in her center? And in fact, what is the right number for her patient population? How can we support access to that level of information to help her best manage her program. And something that's currently being piloted in the Champlain-Lynn that we speak a lot about is this concept of best practice. If baby Alice was born by an elective C-section at 37 weeks and 4 days in a low-risk mom, there's risk that she'll end up in the NICU and have difficulty breathing and may not be feeding well. Why was that elective C-section scheduled at 37 and 4? And whose responsibility is it to monitor best practice and make sure that providers have up-to-date information with respect to these types of decisions and the processes they have in place? So a few different stories just to touch on what we mean when we refer to facilitation of care to try to make it a little more tangible. As you're collecting all this information to answer those questions, there's a lot of other questions you can answer as well. And so at Bourne, we like to consider that secondary use of the information for research. Some work we've done over the past year is around pregnant women in Ontario being advised to be vaccinated against H1N1. We can all remember that last year. And Bourne had the opportunity to augment our data set to try to support research around that, to understand whether or not the vaccinations were in fact beneficial to the mothers and the babies and whether or not there were any side effects. So you can look for some really interesting publications in the coming months coming out of that work as well. And so facilitation of care is what we're all about. It's all about information being made accessible to impact care to an individual, to make sure that every pregnant woman and child in Ontario is being cared for in the best possible way using information we already have available to us. And whose responsibility that is why we're all here, which is Bourne, Ontario. Better Outcomes, Registry, and Network. And really our vision is the best possible beginnings for lifelong health. This statement we came up with a couple of years ago now, and the reason I like it so much is because it really is the best possible beginnings for lifelong health, both for mother and child. This isn't only about the best start for the child, but also the best outcome for the mom as she goes through her pregnancy and afterwards. Something you'll hear a lot about with respect to Bourne is privacy, our right and responsibility to collect this information, how we treat this information, is a big part of what we do. And so Bourne, as OPSS, the Ontario Perinatal Surveillance System, was granted registry status under PHIPA in November 2009. And what registry status means is we are allowed to collect, use, and disclose personal health information without consent for the purpose of facilitating or improving the provision of health care. And so there's that word again, facilitating. We need to be able to show how we're facilitating health care in everything we do to meet our responsibility as a registry. We cannot collect any information that cannot be linked back to how we are going to improve care to an individual. There's a couple of models under PHIPA. There are registries and there are entities. Entities such as ISIS and other organizations are also allowed to collect personal health information, but it's more for the purposes of planning. Bourne is really grounded in care to the individual, and you'll see that come up again and again. As mentioned, we are in legislation, but that's not quite enough to be able to operate as a registry. We also need the blessing of the Information and Privacy Commissioner of Ontario, and as such have submitted, I believe it's about 35 policies and no, higher than that, 45 policies and procedures to them that are under review to confirm how we operate and that we treat this personal health information appropriately, securely, privately, etc. So we are waiting on those approvals now. A key part of those approvals are our purposes, and I realize this is a very busy slide, and I may gloss over a couple of them, but I just wanted to give you an understanding of the core purposes of Bourne. Again, this concept of facilitation of care, how are we going to do that? And the stories we had up front are really tangible examples of what are here. So I'll touch on the first one. A core purpose of Bourne is to identify individuals or settings where appropriate care has not been received and facilitate access to care for mothers, infants, and children. Essentially the missed screen the story of the baby who was born in one hospital, transferred to another, and unfortunately the newborn screen wasn't offered because each thought the other had done it. This is an example of our purpose number one. If Born is able to cross-reference the fact that there was a birth to the newborn screening result and flag the fact that there was no screen offered, that's an opportunity for us to facilitate care to that baby and that baby's family and do something to ensure that the appropriate treatment is provided. So again, there's 6 of these, and they go from 1 to 6 with respect to how close we are to the individual as you move down the list. We're getting into things like reporting to public health, reporting to the Ministry of Health, things like that are all mechanisms by which we can use this data to make sure the care being provided in Ontario is the best it can be. Okay, so we've talked a little bit about why Born is allowed to do what we are trying to do as a registry. Now I want to talk a little bit about who we're doing it with and the organization that's trying to meet these purposes. So first, our community around data collection and use is key. So if we exist to facilitate and improve care, we can only do that by being given the information and by having a community to give that information to inform their business, inform their practice. And so we're very fortunate in that we can collect information on every pregnancy and birth in Ontario through a broad network. So with respect to labor and birth, through the NIDA system, we're getting the details of approximately 135,000 births annually collected from all 109 birthing hospitals. That work has happened over many years to get full participation in NIDA, and it means the world to us to have that very complete data set on hospital births in Ontario. Add to that the midwifery community, almost 500 midwives in 81 practice groups. Now we've got full coverage of hospital births as well as home births, getting us very, very close to that 100% capture of births in the province. Prenatal screening and newborn screening information is also added to the data set, so 84,000 pregnancies annually captured from a prenatal screening perspective. And we believe over 99% of babies receive newborn screening, but really only once we do that cross-reference I talked about earlier will we really know that percentage. We also capture screening follow-up information and some neonatal care information through NICUs in the province. And so again, this is a community where Born is really fortunate in that we're not starting from scratch. There were 5 founding members that came together recognizing the need for an organization like Born, and each of those organizations brought with them a community of stakeholders. And so we're very fortunate that while things seem early for Born, it's really an evolution of many, many years of work to get us here. Here, from a structure perspective, looks something like this. The big box in the top is essentially the operations of Born, the day-to-day operations that we're going to dive into in a little more detail shortly. But then we also have a committee structure that's been put in place over the last year, year and a half to inform the work of Born and to provide the subject matter expertise across the province we need to make good decisions on what data to collect, how to collect it, and how to use it. So we'll start with those committees. There is the Maternal Child Screening Committee, which actually has joint reporting to PCMCH. So the Provincial Council for Maternal Child Health and Born both benefit from the work of the Maternal Child Screening Committee, which is chaired by Dr. Joe Clark. Under that committee, we have the Prenatal Screening Subcommittee and the Newborn Child Screening Subcommittee. So again, as these are subcommittees of the Screening Committee, they have a mechanism to inform both PCMCH and Born and have been incredibly valuable to us over the past year since they got up and running. Maternal Newborn Outcomes Committee, chaired by Dr. Graham Smith, and our Congenital Anomalies Committee by Dr. Ryan, report only to Born. So there isn't that shared structure, but we've used alternate mechanisms to make sure that there is shared membership on these committees and the PCMCH committees to make sure that communication between the two organizations and the two committee structures is smooth. And again, having these committees in place to help us understand what data we're collecting, make sure it's of the highest quality, make sure it's the right data at the right time is incredibly valuable to us. There are a number of working groups under these committees. I believe a couple getting off the ground now are the neonatal working group is one. There's a working group around NT quality assurance. There's a few initiatives just getting off the ground now as these committees wrap their heads around the work that needs to be done. It's also a great opportunity to engage people more broadly across the province. Then we get to the operations of BORN. We're not a huge organization. I think we're about 20 individuals in BORN between staff and contractors helping on the build. But we are split into a number of core areas. So quality, timely clinical information is key to BORN. We can't meet our purposes if we don't have high quality information. If it's not coming out quickly enough to do anything with it, again, we're no better off. And a real differentiator as we talk to other organizations is the clinical component of this information. People ask, well, how are you different than CHI, for example? Well, if you look at C-section rates in CHI, you can understand what your rate is, but you can't actually dig into that information to understand the underlying clinical indications, background, maternal history, all of the factors that might drive that rate. And so we really see this concept of quality, timely clinical information as being fundamental to what it is we're trying to do. And Barb Chapman is our quality management specialist driving that work. Community engagement, obviously we are a provincial program, and while many of us live in Ottawa, we recognize the need to engage with the community more broadly, and as such have a team of coordinators across the province helping us with that, working with the data entry and data use sites to be comfortable with that data, to understand how to enter the data into the system, understand how to use the data, and in some cases even how to action that data to change practice and inform the system and providers, et cetera. And I'll show you a little map of that team in a moment. It was just recently realigned, and so you should have seen an announcement last week on the BORN coordinator team. Technology, many of you have likely heard about through the BORN Build briefings. We went through an extensive RFP process a couple of years ago. Dapasoft was the selected vendor out of 8 proposals that were provided and are doing great work. We'll touch on it a little more in this presentation, but really the BORN Build briefings are where you can get the details around that. Dr. Anne Sprague leads our analysis and research or scientific team here at BORN. They have a very broad mandate, everything from dealing with all the data requests we get, requests from researchers, requests from other provincial programs, requests from the ministry are all handled through that team, as well as doing our own research like the H1N1 project. Privacy. Obviously, getting the IPC submission completed and submitted is overseen by Dr. Pranish Chakraborty as our acting privacy officer. And then finance. Joan Mongeon is leading the ops side of the organization, keeping us on track and providing the underlying support with respect to contracts and things like that required. So really, this is the operations of BORN. I guess I didn't speak to the leadership team, but Dr. Mark Walker, Dr. Pranish Chakraborty, and Susan Richardson, a VP here at CHIO, along with myself and Anne Sprague, make up the leadership team of BORN. I mentioned our coordinator team, and they are aligned to LINS, and the complete listing with contact information is available on our website. But we do have coverage across the province, which means the world to us, both from having a voice regionally, but also having an opportunity to hear from you directly. So that's something we're investing in heavily at the moment because the build is coming live in the fall. Building those relationships and being ready to engage through the fall is critically important to us. Okay, so I've talked a little bit about the community that provides us the information. I've talked a lot about the structure we've put in place to inform and use the information once we have it, and then there's the information itself. When I started with Born a couple of years ago, this was the picture that we had. Essentially, there were 5 founding members. Each member had some type of data set, maybe in one database, maybe in 2, but essentially there was a database of information. We were going to bring those 5 data sets together into a single database so we could go for registry status for that one organization. But what I found fascinating is through the evolution of the organization, through the work on the build, this picture has really changed. And you've probably seen this on Born Build briefings, but we don't really think of it anymore as the 5 founding databases, but rather a continuum that the mother goes through pregnancy, labor, birth, and the postpartum period, and also the same for the child, pregnancy, birth, and postpartum. Every woman and child's experience is different, but there are concrete data points along the way that may or may not apply. So she may or may not have had prenatal screening done. She may or may not have had a more complicated pregnancy, meaning that there was some specialty antenatal care required. Almost all cases there is a delivery and birth experience. And then the postpartum period. And being able to extract this information from existing data sources to build that picture of what that continuum looks like, both for mother and child, is really how we look at it now. And we look at it from a technology, but also from an architectural perspective. And so the vision going forward is as new data sets become available, an example being transport. There's a lot of discussion around transport in the neonatal period. We can add these data sets once they become available. We can add them to this architecture, and we can continue to better understand the woman and child's continuum as we add more information to it. What information are we collecting across the continuum? A fair bit. It is online. The data dictionary is online, bornontario.ca/data-dictionary. And this slide is really just a taste. I mean, obviously there's a lot more to it. There are 110 discrete pieces of information we collect. In some cases it takes some sub-elements to define it. So when you go to the data dictionary, you'll see about 600 unique elements, but really there are about 110 discrete, meaningful pieces of information. Trying to organize that much information proved to be a little bit of a challenge. My engineering brain likes to have everything as an equation, and essentially the way I like to look at it is a woman has a health status in her pregnancy. She's exposed to any number of risks through her pregnancy, and so there's care provided to address both the status and risks, and from that you get an outcome. So I like to think of this as status plus risk plus care equals outcome, and that's the model we tried to use for our data elements. Things like maternal health history, whether or not she's diabetic, any number of lab results can inform health status. Alcohol or smoking are clear examples of risk factors. Care provided could be anything from labor interventions to screening completed. And outcomes, whether they're birth outcomes or maternal health outcomes, APGAR scores, things like that are all considered outcomes. So I'd encourage you to go to the data dictionary, have a look. It is organized by these encounters we talked about, so you're able to go into any given point in time through the continuum and look at what information we collect there. There's also great search functionality. If there are specific data elements you're interested in, just click on search and type in a search, and it'll bring back any relevant data elements. Okay, so once we've collected those 110 data elements and we've defined the picture of the continuum, what can we do with it? And really, again, we're back to those stories. So once we're able to cross-reference a birth with a screening result, we're able to highlight the fact that there was a missed screen. Once we're able to understand clinically C-sections or inductions and things like that, we're able to undertake quality improvement initiatives based on that data and inform practice and change practice to improve care to the individual. Obviously, system planning always has to happen. Our population is always changing, and anything we can do to address those changes proactively is going to have a really big impact. And another one a little earlier on that we haven't talked too much about, but I think is worth highlighting, is improved screening algorithms. both newborn screening and prenatal screening data is captured in BORN. And screening by definition is about setting thresholds related to risk. So whether or not an individual screens positive or negative, a decision is made based on the information collected. But the better we are at setting those thresholds, the better the screening program. And what BORN allows is an opportunity to cross-reference screening results with actual outcomes. So if someone screened positive and we actually have the outcome of that birth and the health of that child, we can bring that information together to improve our screening algorithms and reduce the number of both false positive and false negative screens. So there's huge opportunities in this information. And of course, what it's all about is those stories up front, and anywhere we can use the information we're collecting to answer those questions and facilitate those stories means we've been successful. The build itself well underway. The entire team came together yesterday, actually, to begin planning around user acceptance testing, so we're entering a whole new phase. Design is almost complete. And really, as Dapasoft goes off to build everything we've defined, we have an opportunity to define what testing and implementation of that will look like. This is a very busy slide. I don't expect you to follow it. Beth does a much better job describing it on the BORN build briefings, but you have it here for your reference. And BORN does not do this alone. We started in partnership and we continue in partnership. There's any number of key partners. I'm highlighting just a few here who we're doing this work with. So BORN is funded by the Strategy Division of the Ministry of Health and Long-Term Care, so a lot of our work happens with the Ministry of Health. The Provincial Council for Maternal-Child Health is a key partner, and in fact, we've adopted the shared vision of Best Possible Beginnings for Lifelong Health across the two organizations, and we're now just finalizing aligned mission statements. We don't have the same missions. They are very much around policy, while we are information, and those two go hand in hand, and the closer we work together, the more likely we are to be successful. So there's been a lot of growth in that relationship over the past year, and it's working really, really well. Ministry of Children and Youth Services, obviously we are talking about a continuum, and that continuum logically leads to things like 18-month well baby, school readiness, things like that. So we're working closely with the Ministry of Children and Youth Services to understand what that might look like in the future. Public health has a long history with NIDA and now with BORN, and depends on our data. We meet with them quite regularly to understand their requirements in our data set and how that can be facilitated through the BORN build. Health Quality Ontario, I think I got that right. Previously OHQC, Ontario Health Quality Council, obviously taking on new responsibilities under ECFA, and given the data aspect of both organizations, we're partnering with them to make sure that we're aligned and collecting and providing appropriate information for requirements around the Excellent Care for All Act. ISIS as an entity, a registry and an entity are allowed to share data, so there's great opportunity there to link our data with ISIS for research purposes and for system planning purposes. So that will be happening through next year. And finally, Service Ontario. There's work around birth registration in the province and being able to cross-reference the BORN data set with the birth registry to make sure we have the highest quality information possible around births and deaths in the newborn period in the province. So these are a number of partners. There are many more, but I just wanted to highlight a few so you have an understanding of where BORN is working. And where do we go from here? One of my favorite stories. Really, when the build goes live in the fall, there's going to be a cohort of babies born at the very same time, and one of them may well be baby Isaac. And when baby Isaac is entered into the BORN system in September, October, November, he will hopefully continue to grow and thrive, and we would like BORN to grow and thrive alongside him. So as he goes for his 18-month well baby visit, we would like to be able to add 18-month well baby information to our data set to continue that continuum and to allow for that linking of early childhood information into childhood to inform each other. When he's ready for school, we would love to have school readiness information. When he goes and writes his grade 3 EQAO tests, if there's information we can draw from there to really understand the continuum and to understand the trajectory and understand how things that happen early in childhood are impacting growth and development, that's really what Born is all about and really excited to do. So we're going to let Isaac drive our growth and grow up alongside him. There's no point in us going and getting school readiness data if we have no children to link that information to earlier. So watch us grow with them. And really, that's it. That's Born. We've touched on privacy. We've touched on operations. We've talked about the committee structure. We've talked about the technology. So with that, I would like to open the floor to any questions you might have about the operations of Born Ontario. As mentioned, just press 01 to be placed into the cube, and I will do my best to answer your questions. I've got a number of people here to support me when I don't have the answer. So it's 01 to ask a question. No questions in the queue. Oh, hold on. We've got one. So 519.
Hi, it's Marianne from Perth.
Hi, Marianne.
Just curious, are you using the Parkin for your newborn screenings?
Newborn screening at this point is dry blood spots. But we are having conversations around other types of screening through the newborn period and whether or not there's an opportunity to add them to the data set going forward. But when we refer to newborn screening in this particular presentation, it's Newborn Screening Ontario, the heel prick, the dried blood spots.
And every child has to have one of those?
Yes, they do.
Oh, okay. And then you mentioned how will you be getting prenatal? The same, a blood test too then?
Yeah, so that's that's Prenatal Screening Ontario, which I think is MMMMSS is how it's often referred to, but it is sorry, I'm just turning to Kim here, specifically around which prenatal screening tests are in scope for the data set we have.
I was just curious because the ministry is bringing out a new tool that's going to go across the spectrum. The idea, the same tool will be used prenatally, postpartum, and eventually early ID. And it's being piloted by a few health units right now and supposed to be coming in the fall. So I just was curious if that's how you would get your information, because it would be very interesting to have the whole spectrum. But
absolutely. I'd actually be quite keen to speak to you about that, maybe offline, to learn a little bit more about that longitudinal view on it. But what we're collecting at this point is the blood work done prenatally, often first trimester screening with the nuchal translucency measurements associated.
Okay. Thank you.
Thank you. Next, I think we have a 416314. We're just going to unmute you.
Hi.
Oh,
Hi.
Hold on. Okay.
Okay, can you hear me okay?
I can, thank you.
Okay, thank you. It's Nancy Garvey, and I'm wondering if with your data dictionary, and I haven't taken a look at it yet, but have you endeavored to define the data set in terms of something like SNOMED nomenclature, or have you had or intend to have endorsement from the Ontario Health Informatics Committee? Anything like that?
So we are doing work. We did a fair bit of work around SNOMED as compared to ICD-10. And our initial assumption had actually been SNOMED, but in the end our advisory committee ended up suggesting that we align with ICD-10 in the short term and then with ICD-11, which is expected to be aligned with SNOMED. So definite work having been done there. The Ontario Health Informatics Committee is not something that has crossed my radar. I'm just turning to Barb Chapman here to see if she has anything to add. But I would be interested in learning more. We have tried to stay aligned to standards wherever possible,
right.
Given that a fair amount of our data collection is automated and we need to play nice with other existing systems. But I will definitely look up the Ontario Health Informatics Committee to see if there's any more work that should be done there.
Okay, thank you.
Thank you. I think our next one is a 519 area code, 519322.
Yes, hello, it's Rebecca Ismail from Leamington.
Hi, Rebecca.
And we were just wondering if you could put, we were unable to pull up the PowerPoint part of this presentation.
Oh, no.
Can you send it out online?
Absolutely. We'll post it on our website, and I'm hoping that this has all been recorded so that, in fact, you'll be able to watch the whole thing as well if that's easier.
Thank you.
My pleasure. So I don't have any more questions on the phone. Again, it's 01 if you did want to ask a question. Oh, we've got one more. Hold on. A 905 area code question. Good afternoon.
Hi, my name is Anne-Marie calling from Markham-Stouffville.
Hi.
I'm just curious as to how the transition will happen from the NIDA collection to the BORN collection. How is that rollout going to be? Or will we have sort of a double data collection until BORN is, so you're not missing anything in the interim, or how is that going to happen?
That's a really good question. That's sort of the work that's being defined right now by the BORN Build team, and I would encourage you to dial into the next couple of BORN Build briefings because there will be a lot more information there. But essentially, there's recognition that there will be a transition period. We don't anticipate dual data entry through that transition. It will most likely just be well managed to allow for NIDA up until a certain point in time, transitioning to BORN on a given date. But those exact dates are still being defined.
Okay.
Again, BORN Build Briefing is the perfect place to learn all about it.
Okay.
Put in a little plug. Thanks. I think we have another question coming out of area code 705.
Andrew Gerhardt calling from Sudbury.
Hi, Andrew.
I was just wondering, looking at the sort of listing of your partnerships, I didn't notice anything that was sort of specifically First Nations. Can you sort of explain on how, if at all, there are any sort of distinctions between the finding out which of the data sets involve First Nation communities and how you're able to
Absolutely. Happy
do that?
to. Yeah, so First Nations is recognized as an area we have more work to do, both around our data dictionary and data collection. And we are just starting to build the relationships required to understand that and gain the necessary approvals to do that. So it's an ongoing project. Deshane Fell is an epidemiologist within our research and analysis team, and she's really driving that work. We're looking to partner with other organizations like Cancer Care Ontario and others just to make sure we're following the appropriate processes to be able to do it. But it's a work in progress. It's not yet fully fleshed out.
Okay, great. Thanks. I know it's very tough, especially looking at postal codes in the what we now call the Great Orange North after Monday's election. They can have the same postal code over 100 kilometers apart, and it's
right.
just not simply as easy as other parts of the province. So
yeah, understood. No, there's definitely some work to be done. I can appreciate. Thanks for the feedback.
Okay, thanks.
I think we have another one now in area code 613.
Yes, just wondering, is the intention to tie this to the provincial EMPI as well?
It's a good question. When the RFP originally went out, there was a requirement in the build to integrate with an EMPI. The BORN technology does have a linking and matching algorithm to allow for any number of any number of identifiers to be used. But in this phase of the build, in this first phase, there is not an integration with the EMPI. It is a future vision of the project.
So we would be responsible for all the demographics and everything. There wouldn't be an electronic feed for any of that?
That's a good question. There are electronic feeds in that some of the hospitals are actually doing electronic feeds from their hospital information systems into Bourne. And so in those cases, there's no re-entry required. It's actually pulled from their HIS and pushed to Bourne directly. Another area we try to minimize the need to re-enter that type of information is anywhere it already exists for an individual, we're able to pre-populate subsequent manual data entry screens with the information so that we're not keying it in multiple times. So if, for example, some demographic information came in with a prenatal screening result, when the labor and birth information is going to be populated, anything that was already entered against prenatal screening will pre-populate and reduce the need to re-enter it. So not pure EMPI integration, but doing our very best to minimize the amount of data you need to enter.
Thank you.
I think we have another question from area code 807.
Hi, it's Sue Lookout Mental Yellow Health Center calling.
Hi.
My name's Leanne. I am the clinical coordinator for the Matt Child department here. We do 80% of our deliveries as First Nations. So we are doing the data entry for the labor and delivery. However, access to the antenatal care for the women who are in the fly-in remote communities north of us in our zone, as well as the zone on James Bay. If you guys need any help or support or have any questions, please don't hesitate to call me.
Oh, that would be wonderful. Would you mind dropping me an email?
Sure.
Sorry.
I'm just not sure what your coordinates are.
Yeah, so on the screen now there's info@borneontario.ca.
Perfect.
If you could just say for Mari, M-A-R-I, I'll make sure I get it, and I'd really appreciate a conversation at some point. Thank you.
Right on.
Thanks. Another question coming out of 613.
Hi.
Hi.
It's Janice Menard from Queens. I'm just interested in what percentage of your data entry is at point of care and electronic?
Specifically to labor and birth information or across the entire system?
Well, maybe you could answer it two ways. One, across the entire system, and of those 5 that you mentioned, which are electronic?
Okay. I'll do my best. So I'll start at the beginning. Prenatal screening is an electronic batch upload of lab files into our system. So light touch labs will upload existing flat files into Bourne. Then we get to what was known as the fetal alert network. So congenital anomalies information is manually entered into the system. Then we come to NIDA, which is labor and birth information, and this is a mix. There are 14 sites that do batch uploads, so they're able to extract information in an automated fashion from their existing hospital information systems into the Bourne system, so all electronic, while the rest of the sites do manual data entry, so keying it into screens. Then we get to midwifery, which is also manual data entry, and finally Newborn Screening Ontario, which is actually an HL7 feed. So this is our leading-edge technology data collection as we collect information from their lab systems through HL7 messages.
Thank you.
Then there's also the screening follow-up sources, both for prenatal and newborn screening, and they are manual data entry as well.
Great. Thank you.
Okay, my pleasure. Just going to check if there's any more questions in the queue. No more questions. Very good. So I just want to thank everyone for taking the time to learn about Bourne and describe a little bit what happens going forward to minimize confusion. But essentially, these calls will happen every 3 weeks, alternating between Bourne Build briefings and Bourne Ontario briefings. The Bourne Build briefings, as I mentioned, are focused on the technology, on the changes that are happening over the coming months with that new technology. And the Born Ontario briefings will continue to focus on the operations of Born. We will have one on privacy and Born's responsibility with respect to being a prescribed registry. We will have another on the work of our research and analysis team and the science happening using the Born data. And if you have any other suggestions on things you'd like to learn about with respect to Born, please just drop an email to info@bornontario.ca. And we appreciate your feedback and ideas because it's become abundantly clear that there is so much work to be done, and your feedback on exactly how we prioritize that and what's most important to you truly means a lot. And so with that, I'm just going to double check no more questions in our chat. Nope, I believe that's it. So thank you very much for your time. I look forward to hearing from you all. Take care. Bye-bye.